Welcome to the Inside Angle podcast. I'm your host, Dr. Travis Bias, family medicine physician and Deputy Chief Medical Officer of our Health Information Systems business here at Solventum. I am joined today by Dr. Richardson, Chief Medical Officer and VP of Medical Education at Conway Medical Center. Dr. Richardson, thanks for joining us.
Hey, thanks for having me. Appreciate it.
Yeah, sure. So start out just briefly, talk a little bit about yourself, introduce your background, talk a little bit about your role at Conway, and then we'll go from there.
Sure, absolutely. So again, Paul Richardson, Chief Medical Officer and VP of Medical Education at Conway Medical Center with Novant Health in Conway, South Carolina. We're located right near Myrtle Beach. I'm an internal medicine doctor by training. I did my medical school at Medical University of South Carolina in Charleston, and then I did my residency at Wake Forest University in Winston-Salem, internal medicine. I had a private practice in Conway for about 13, 14 years before I transitioned over to administrative medicine, and I just kind of fell in love with this side of the equation, so to speak, and had a role there as VP in some informatics for about a year or so, and then my predecessor retired, and so I was hired into the CMO role at that point. So I'm responsible for all things medical staff. I'm also responsible for all things quality at the organization. I have a role with the trauma service, stroke service, various other services there. In my VP of Medical Education role, we do have training programs. We're a community-based training program. We have family medicine transitional year, a non-operative sports medicine fellowship, and we also have an affiliation with Campbell University, which is an undergraduate medical school out of Bowies Creek, North Carolina. So we host 11 third and 11 fourth year medical students. So at any given time, we have about 60 medical learners at Conway. Busy.
Sounds busy, and informatics, medical education, quality, all topics we like to talk about here. So I appreciate you sharing that background. And you can't see us, obviously, this being a podcast. He's got his bow tie on, which is very much on brand for the medical education side.
Yeah, bow tie. Got to be an internal medicine doctor if you wear a bow tie.
Very public health conscious. So as CMO and as a physician leader, I guess you talk about a lot of these topics over which you've got kind of some accountability. How do you think about your role as a physician leader and kind of bridging from clinical care and excellence and performance improvement there to documentation and across kind of all those domains? How do you see your role there?
Well, I look at my role as really being sort of, I know we talk frequently about having physician champions in various, usually maybe a service line or whatever. I guess I'm kind of the physician champion for the organization. I have to be sort of the person who does that, right? I have to be the person who interfaces with the physician champions and the frontline physicians. And so I love that role. That's a role I really, really enjoy. I always enjoyed the business of medicine anyway. So for me, it's translating that, again, for lack of a better term, the business part, the part you talked about around, the quality and the documentation, translating that to the bedside and how those two do interface. Those are very much need to be aligned and should be aligned. But I think that your rank and file, we weren't trained for this in medical school. So when you come out of medical school, you may not see how those kind of things align, but they definitely do. And they need to align more if we're going to get the best outcomes, not only for our patients, but also to make sure that our externally facing metrics reflect the excellence of care we're given.
That's it. So I like that you mentioned that we weren't trained for this. I think back to residency where I was having to learn clinical medicine. I was having to learn how to navigate my electronic health record. And I was having to learn ICD-9 codes at the time and CPT codes. I mean, these are very different languages and things that you are not taught during your undergraduate years. And so I'm glad you bring that up because, when you are trying to engage your frontline clinicians around documentation and coding, that can feel like just another headache or just another burden on their shoulders as they move throughout their workday. So I guess, how do you communicate to your physician staff kind of why that should matter? Why should complete and accurate documentation matter to the care they're delivering every day?
Well, and remember, I'm a good bit older than you. In my day, it was navigating the written medical record and really having our quote unquote coding education was one of your upper levels, telling you put X, Y, or Z code down. I mean, that was truthfully our medical education. Today, more than ever, we're under scrutiny, right? We're under scrutiny from various outside organizations and internally as well. And so to me, it's assisting my physicians, my colleagues in understanding the ramifications of that. And also the fact that, when we're talking about CDI specifically, had several very, very, very good educational sessions around that at my place and had a doctor come in and do that, expert come in and do that. Really had great engagement from a lot of my docs. But many times when you tell them the why, that's the key. You give them the why and then they'll take it from there. And for instance, my chief of surgery, he really latched onto this, and our annual medical staff meeting was coming up, I think within just a few weeks of that education. He actually sought me out and was like, "Hey, listen, I want to take 5 or 10 minutes and just go through this in front of the medical staff." I was like, yeah, is the answer. Heck yeah. So he got up. I didn't have to be right, because sometimes they get tired of hearing me talk. I didn't have to do it. I mean, here's my chief of surgery standing up there saying, listen, guys, Conway Medical Center is getting the scorecard now, but come down the road, we'll all get the scorecard. It'll be my name out there. It'll be my numbers. We need to learn this stuff. We need to figure out how to do this so we can do it appropriately and properly.
Well, you mentioned being kind of the ultimate physician champion in your organization, but I think having multiple physician champions and that physician voice from the chief of surgery, a lot of times I feel like people at whether it's your geographic location or within your specialty, you want to hear from certain messengers about whatever it is that you want to incentivize them to do at your organization. And so I think that's important that physicians hear from their own when it comes to, like you say, why is this important? Why do I need to engage with some of the CDI queries that are landing in my in basket?
You hit the nail on the head there, because still in our world, number one is physicians want to hear from physicians. I mean, that is what it is. I'm sorry, that's just the way it is. I can't change it. And we are very sensitive to our own specialty for whatever reason. And I don't know why we do that. So I get that. So you're definitely hearing from, and not the administrator, quote unquote, but hearing from a respected. I mean, I've been on the medical staff there 24 years. My chief surgery's been there right at 30. So hearing from someone with that kind of longevity and that kind of respect among the medical staff meant a lot to me. And I was like, and I didn't have to suggest it. That was the greatest part of the whole thing.
Well, I think, when you talk about quality and you talk about scorecards, what I have seen and heard, physicians are more and more in tune to how they're being judged, no matter who's producing the scorecard. Maybe it's the payer, maybe it's a government, maybe it's some other entity, analytics platform we were looking at. And so we're seeing a lot more, organization level transparency, but physician level, practice level transparency around quality measures. And so I guess, how do you think about physician accountability in that environment? Because you're going to get pushback, I think, from some of your physicians about how they're being measured. And in some of these cases, the measures, they are what they are, and we can't really control those. And so how do you move your physicians towards, hey, you're going to be on the scorecard one way or the other? And, what I explain is, a lot of these expected values and quality measures come from your documentation. And so that's why some of these CDI pieces that we talk about, the clinical documentation capture, is so important. So how do you think about accountability in that environment?
Well, I'll answer that question like this. Right, wrong, or indifferent, we have a very tribal mentality in medicine. We also are quite competitive. I mean, just by nature of the beast, so to speak. I mean, it is what it is. Again, it's something else I don't necessarily need to understand, but I know that. So, sometimes you have to lean into that. And I do believe in transparency at my organization. Sometimes maybe a little bit too much, some people might say, but I do believe in transparency. I do believe in presenting the data. And then a lot of times nature will take its course, so to speak. I mean, you have a lot of docs who are like, wait a minute, whoa, I'm at the bottom. I can't be at the bottom. I've never been at the bottom. And so, frankly, that becomes a great motivator, a great tool. I find it sometimes, if you try to incentivize a lot of these things financially or whatever, that may last for a short amount of time, but it's not going to last forever. So that really is a bad idea, bad plan, long-term, in my opinion. But when you really use that competitive spirit, so to speak, and then the other thing, to be quite frank with you, I mean, and maybe I'm romanticizing this, people are still in our work for the right reasons. And so a vast majority of physicians are in it for the right reasons. And so when you present them like, look, this is what you look like, they're like, I don't want to look like that. I mean, again, I'll use an example. I mean, currently, if you look us up, we're 2 stars. We're not a 2-star hospital. We're not. Period. Amen. Okay. So that bothers me to my core. I wake up and go to bed pretty much thinking about that. And so, we're definitely on the upward slope of improving it, and we're going to improve it. That's my mission over the next few years. But we're not delivering 2-star care. So any doctor who sees him or herself as a 2-star doctor, if they're worth their salt, they're going to want to improve that.
Well, and I think getting that slope upward curving, as soon as possible, takes kind of aligning clinicians to the CDI and coding worlds that we know and talk about here, kind of coordinating all of that. So how have you seen that done well, or how do you think you all are doing it well? Obviously, you're held up as a great example of that, while keeping all the care patient-centered, of course. Like, there's still all these documentation pieces where clinicians need to focus, but also, focusing on their patients. How do you kind of align that for your physicians?
Well, to me, I think that we're delivering that excellent care, but we also got to tell folks how we are delivering that care. And when I explain this to doctors, my colleagues, I mean, it's also for your patient benefit. If you're not accurately reflecting the complexity of your patient, then he or she may have denials, because we know how that works. That's a whole different topic. We could do a podcast just on that. But that notwithstanding, they may have denials that they otherwise would not have. And so you're actually potentially not only not relaying the information accurately for them, but they may actually incur bills they wouldn't normally. So this thing is so multifaceted. And I think that's the other thing that docs don't understand. We don't get told that. In my day of training, we had zero insight into the medical bills. We ordered tests and we just did whatever we wanted and didn't really think about that side of it. We can't do that anymore. And also that patient responsibility, we have to be cognizant of that as physicians. We have to, in my opinion, I know we need to do the right thing and we will do the right thing, but we also have to do everything in our power to make sure that, we're taking care of that patient fully.
I think it takes you framing it like you're framing it, just the way you describe how this may impact your patient. It maybe makes some of your frontline clinicians think about it a little differently. Like, hey, the documentation, yes, it's a headache in certain regards, but it is required for payment, of course, accurate quality measurement, quality handoffs of your patients from one team to the next. I think there are a variety of reasons that we want to document completely and accurately. And so I guess, from your experience, documentation quality, how does that actually impact your teams? And so whether that's from like workflows to performance to actual patient care, just say a little bit more about how that's impacting your teams.
Well, it's impacting my teams in that, frankly, we're not getting credit for work we're doing. We've only been at this journey really less than a year, frankly, full bore. So with some of the data that we were provided, based on our severity of illness and those kind of factors, it made it look like our patients were about 25% healthier than average. Now, keep in mind, I'm in South Carolina. I'm in the stroke, heart attack, you name it, belt, right? I presented that to some of my medical staff. We were having a chat about that, and I threw that up on the screen. And I showed them and walked them through that. And I said, so basically what I'm hearing, everyone, is we're taking care of the marathon runners and the folks that are probably underweight, not overweight. And everybody was like, heck no, are you kidding me? And so I was like, well, that's what the data shows. That's what our documentation is showing. And so that got some attention right away, that, wait a minute, what I'm doing is not being reflected in all the effort I'm putting in. I was like, no, CMS thinks that our patients are 25% healthier than the average person in South Carolina. So you must be taking care of marathon runners and people that, that are eating right and eating healthy and their blood pressure is all controlled. And everybody was just dumbfounded by that. I thought that was one of those sort of aha moments, right? Where they really were like, are you kidding me? I was like, well, it's right here. It's not my data. We just pulled it out of, the governmental database.
It reminds me of a slide I saw that was like a side-by-side comparison on one slide that said, the picture on the left is what's documented, and it's a healthy looking man in a polo, looks like he's about ready to go play golf, and he's got, sore throat, shortness of breath, some like general documentation codes. And then on the right is a guy intubated in the ICU. And it's like, this was the actual patient, but the documentation looks like it's this guy about to get up and go play a round of golf.
Correct. And that was exactly what I was trying to say. We're not accurately reflecting the complexity that A, reflects poorly on us, B, affects our reimbursement, and then C, it can potentially affect the patient downstream just from our documentation. We don't think about that. We weren't trained. I'm trying to make it clear to medical staff, it's not our fault. We weren't trained for this, but it's the world we live in. So you either get in the stream or you're going to get swept behind.
Objectively, this is what the documentation is showing. This is what we look like right now in our data. You and I both agree it's wrong. So let's work together to right this. And so that brings me to physician engagement, something I want to talk a lot with you about. How do you get your physician, truly engaged in this? Like, what have you seen that actually works to get physicians engaged, not just compliant and checking all the boxes you need them to check, but like truly engaged with documentation, accuracy, completeness, and performance measurement?
For me, it's just complete honesty. If I had to give one word, I'd say honesty, and the second word is transparency. And I know I sound like a broken record over here, but it's not some kind of sleight of hand or we want you to do some, fluffing it up. It's just being point blank honest. Here's where we are. Here's the problem. Here's the issues. Now, how can we work together as a medical staff to better improve and fix it? And also having really good education around it. It's saying you said X, Y, and Z, and that resulted in the coding of here. The patient, it really had A, B, C though. So that needle would have moved dramatically. Well, that's what the patient had. I understand, but that's not what you said. So to me, engagement comes through that. Also, what we talked about earlier, we're competitive by nature. And we don't want to be at the bottom of anything, right? I mean, if I'm going to a doctor, I want to make sure he or she was at the top of the class, and we're accustomed to that. And so they want to be better. I just find that most people want to be better. So it's really when you be honest, you be transparent, you're not trying to fool anybody, so you don't come across as if you are. And to me, that made all the difference in the world. That's why we have a 100% response rate right now at Conway. That's crazy. I never anticipated we'd be this far, this fast, ever in my wildest dream. I wanted CDI for a better part of 10 years. When we finally got it. We're an infant in this journey. So I'm excited to see what the world will be like in 2 or 3 years. It'll be crazy.
Yeah, I think that those are fantastic themes. And I think one of the other things you mentioned earlier was getting to the why. I mean, I'm a fully trained professional. You just got to get level with me on why do you need me to do this? Because a lot of times if you just tell me, hey, just do this, just click this checkbox, I'm going to push back. But if you tell me, hey, this is really impacting maybe the organization, maybe your specific practice within the organization, your patient care, obviously the quality measures externally, this is what we look like.
Here's the other beauty of it. This is not something in our wheelhouse. However, as we get more adept at this, you'll get less queries. We learn, we adapt. And so just leaning into that a whole lot makes a big difference too. I'm like, let us teach you. You're doing the work, so get credit for it. Let us teach you what we need to teach you in order to make you better. And so I really think that makes a difference too, in that, the docs are like, hey, I want to get there. And the other point I was trying to make there was too, is it's really not more effort than what they're doing now. It has to be more accurate and targeted, accurately describing and telling the story. That's it. We're on a journey to truth. We don't want to go above truth because that's an area you don't want to be in. We want to be at truth. And so that's where we need to be.
Being more targeted, I think there's still a lot of documentation myths out there, things that I probably still document because in residency, I had an attending tell me 17 years ago that this is what I'm supposed to put on every note. Actually, you don't need to waste your time with that, but we do need to spend our time focused on these pieces.
Right. Well, you think about a lot of stuff in medicine we do because Dr. So-and-so told us to do it. He or she did it because Dr. So-and-so told them to do it. Well, maybe the first doctor didn't know what they were talking about, and now they're passed it down for generations and generations.
How do you think about, still in this physician engagement, when explaining the why, I think there is this somewhat misconception that doctors don't want to be talked to about revenue, about the financial side. And so there is this financial incentive. We can just be honest about that. But there's also this whole other track of engaging your physicians based on the quality measures and what we look like. Do you use both of those tracks? Do you really try to lean heavily on one versus the other? Because I feel like if you shy away from the financial motive of your organization, let's say, people aren't going to see you as transparently. I mean, what's your attitude around that?
My attitude is you got to use both. And again, we have got to be patient-centric. We've got to be. But let's be quite frank. We can't operate with massive losses either. We'll close down. Then no patients get taken care of. So we have to be transparent on that front too. And if I have a surgeon, who's requesting $1 million+ robot, please don't tell me you're not interested in hospital finances, because you better be. How else are we going to be able to do those things and provide that technology for that services, which I'm a huge fan of. I love the technology. And I think that we're doing great things for patients through that technology. But there's no way we can afford these things if we aren't cognizant of the financial ramifications. With that said, obviously we want to be patient-centric, and we want to make sure that the quality metrics follow that. My boss uses a saying, I've heard him say this a million times, a non-physician, by the way. He's like, take care of the patients and the money will follow. I 100% believe that. However, we also have to be cognizant of both sides of that equation. At Conway Medical Center, we have 4 pillars. It's patient satisfaction, employee satisfaction, quality of care, and financial sustainability. So we revolve around those 4 pillars at our organization, and every single one of those are equally important.
The practice of medicine is changing rapidly right now with the introduction of new technologies and obviously AI. By the way, we got 25 minutes in without mentioning AI.
That's pretty doggone good this day and age, right? I mean, AI is every conversation we have.
Yeah, well, but the practice is changing dramatically. In the next 5 years, 10 years, the practice of medicine is going to look very different. So how do you think of physician engagement? Do you see generational differences? And obviously, maybe another touchy subject, but your physicians that are 30 years out, 15 years out, and have just graduated 2 years ago or 2 months ago. Do you see differences in what your physician staff need to perform at their best, I guess, in general? I mean, obviously thinking about documentation quality somewhere in there.
Being one of those more senior physicians, I do see some of that. Let me explain it this way, though. I do think that our younger generation physicians adapt more quickly to technological advances. That's a fact, and I've witnessed it with my own eyes. I do think that more senior physicians like myself do require a little bit more support in those. However, what I still see, though, is that myself and my senior colleagues still have that desire to do the right thing for the right reasons, which, again, not saying the young docs don't, they do too. So that common thread to me leads us right to the same intersection of doing the right thing for the right reasons. How we get there might be a little different, right? Dr. X, who's been out 30 years, he or she may need a little bit more support to, let's say, make that AI product or AI technology go live, as opposed to Dr. Y. He or she may only be been out 5 years and take to it like a duck to water. So we just have to be mindful of that and just make sure that we're really providing the right service to that right cohort. Everything revolves and evolves back to that point where we're doing the right thing for the right reason. I mean, I've seen some of my docs, more senior docs, that have absolutely, I mean, they are all in and really taken to this, which has been very, very cool.
As a geriatric millennial myself, Oregon Trail generation, I think there are some strengths to have straddled, some of the technology where I didn't grow up with a computer in my room, but I also, sought out a residency program that had an EMR maybe fully deployed before some others, right? So I think there are some strengths there. Now I've practiced on 10 plus EHRs throughout my career, so I have a little more adaptability, I think. But I think what you said kind of goes back to one of your original points, that you need some education, and physicians just need the tools to do their job well, and they'll sort it out, right? You just need to give them the support they need. And like you say, the support may be different based on kind of their practice experience.
Correct. And again, we're clever people. We are a smart bunch, or should be. I hope my doctor be smart, but we adapt, and you provide consistent, transparent, truthful data. 9.999 times out of 10 respond positively to that. There may be a little bit of dust up, but you work through that. I tell my colleagues all the time, I say, listen, we're a family. Families have disagreements, but in the end, family's going to hug. We need to make it up, move on, and do what we need to do to take care of these folks that have trusted their healthcare to us.
Sure. That's a great message. So on AI, you mentioned some of your informatics background, and I mean, you cannot do your job without deeply understanding the informatics implications of a lot of these topics we've been talking about. And so I guess looking ahead with AI, with it evolving so rapidly, how do you think AI is going to reshape all of the documentation, coding, clinical practice in general? I mean, how have you seen it already, I guess, in your organization, and where do you see things going?
Well, number one is, I think it's long overdue, some of the help, right? I'm a fair bit ahead of you in training, where I came out with really no EHR. You came out just as EHR was really emerging. In my personal opinion, yeah, I mean, as I saw EHR, the electronic medical record, come in, it's quite burdensome. So the fact that we're now injecting AI into it is exciting, and I really think is going to be a game changer. It already kind of is, because in our place, we've incorporated ambient AI into our outpatient clinics. I've had several docs come to me and say, game changer. It is literally a game changer for me, in that I'm not spending sometimes hours, hate to say that, after clinic doing notes away from your family. To me, we're going to see, I'm sure there's going to be some negatives, but we're going to see more and more positive things as that continues to evolve and get smarter. I'm not conspiracious here, like AI is going to take over. I still think, we human beings are still going to have to do the thinking, but to be able to automate some of those tasks that these docs were having to do themselves is going to be a game changer, in my personal opinion.
The amount of time in the early EHR days that I spent reworking templates and checking checkboxes, the review of systems should, if they're not already going away, are going away, to where I can now focus on the things I actually want to synthesize, to do the more complex, higher level thinking that you actually want your physicians doing. And the ambient tools that you describe, these AI scribes, I guess is a more general term, that's a tech that I feel like, first time in my career, this is not like a top-down thing where you have to convince physicians to use this. Like, the physicians have been using it for 2-3 years since it's been out now, and they're the ones telling you, we have to have this.
At our place, we started out with just like a quote unquote pilot test group. We about had the doors beat off for people once they heard their colleagues talk about it. I mean, we literally were, about to be run out of town if we didn't roll it out. So it really caught on quick.
Yeah, but I think those are the tools that are going to succeed, right? It's the ones where you can clearly see how it's going to make your workday better, make your workday easier. And it's not some top-down organizational mandate that this is the new bell or whistle. So that's one use case, right? Is like the documentation capture kind of on the front end. Where else do you see AI helping or needing to help, I guess, in the next couple of years?
Oh, 100%. I can give you a real life example. We just got a fairly sizable grant to incorporate AI into our mammography program. As you probably are well aware now, especially with like advances in 3D technology mammography, there's a ton of images being produced. And so we actually are bringing in and have an AI overlay, whatever the right term is. I apologize if I slayed that term, but basically it's going to help the radiologist. Not that it's going to read the X-ray for the radiologist, but help basically say, point here, look here, look here, look here, look here. So it makes it easier to go through that volume of images. Now, what that's going to do from a practical standpoint for us is that now that radiologist is going to be able to be more efficient. More efficiency means more appointments per day, more patients getting, diagnostic mammograms, shorter wait times from an abnormal mammogram to a diagnostic mammogram. I've just whittled off about 4 positives, none of which involve finances. Now we're talking patients. We're talking, I get it. You get an abnormal test result, especially around like a mammogram. That is very emotionally disturbing and very emotionally charged. Heaven forbid you have to tell that lady, you got to wait 3 weeks. We don't want that. We want it to be, we'll get you in tomorrow, whatever the case may be. So anything we can do to make it more efficient is what we're looking for. And that's just an example of what is coming and has come to Conway Medical Center. It's going to help our patients.
I'm with you that we probably both seem like AI hype people, but there are just endless possibilities around how much it can make us better at our jobs, I think, if done well, right? If
Correct.
Implemented well, if trained appropriately, the AI tools are trained on the appropriate data to mitigate any kind of biases or things like this. But I do think there are so many of those that will simply improve our efficiencies and kind of free us up to then do the things we were drawn to medicine to do in the first place. And like you say, like the patient experience, there's so much space for us to improve in the patient experience. You talk to like your neighbor, your friends about engaging with the healthcare system, and it's usually a frustrating story you're hearing. It's not like, and even recently I picked up a medication for my wife, and it was like far more complicated than I thought it was going to be. And I'm a family physician and I work in this space, right? It's one of these things, like I think there is so much low-hanging fruits right now to really improve that experience.
And we've got to, because, my generation and older, they might put up with Dr. So-and-so kind of being, a jerk or whatever. Well, that's just the way it is. Younger, they're not going to do it. So we've got to bring tools to bear in order to do that. And the payers have gotten sensitive to that, right? I mean, when I started my career, there was no HCAPS. There was none of this stuff. And so obviously the payers have become more sensitive to not only do we need to deliver world-class healthcare, but we've also got to deliver a world-class experience. Our executive team, we do orientation at our place and sort of meet the executives. So every new class of new hires we do. And I always use this example, and I always say, hey, listen, so obviously we're here to help people. We're not here to hurt anyone. I said, but if we have a patient, we do the right thing, they get better, but they have a terrible experience. Have we really delivered quality care to them? They got everything. They got better, they got well, their surgery went great, whatever, but they had a terrible personal experience. Have we really delivered that quality of care to them? My answer is no, we have not. And so we really have to be cognizant of both sides of that equation. We can no longer just ignore, oh, well, I don't really care what they think. I'm going to do what I want to do. We've also got to deliver that part of it. So that's a long answer to say this is I think that these tools will for sure help us to be more front facing that patient, not banging on a keyboard or, fiddling around with some of that kind of stuff. Now we'll be able to focus in, dial in. That's what we all went in this for. Everybody's medical school application says I want to help people. So now we can actually help people rather than bang on keyboards.
I think that's a lovely thought to end on. I'll ask one kind of final, quick wrap-up question. But if you had one message for physician leaders navigating this space today, what would that be?
That one's hard. I think what I would tell fellow physician leaders is, again, I'm going to sound like I'm beating a dead horse. Just be transparent, be consistent, and be persistent. And I don't mean persistent in a pesty or, just aggravating way. I'm talking about just be on point on that message all the time. You will get results. Meet people where they are. You have to tailor it depending on your audience or who you're talking to. You have to be enough self-aware that you can meet them where they're at. But it does work. It can work. It will work. We can make a difference. As a physician leader, that's what excites me, is trying to affect a body of patients. I love the one-on-one. I love affecting each patient's life, but it's cool to also think you may have a positive impact on a whole body of patients.
Dr. Richardson, really appreciate your time and your insights. Thank you so much for sharing.
Thanks. It's been a pleasure.